this session. And thank you everyone for joining. So happy to be here with you. All right, so left bundle branch block and left axis deviation. So a few things we always have to review whenever we're going to have any discussion at all about the myocardium, the electrical activation, the mechanical response, is we always just want to remind ourselves about this beautiful, incredible coronary circulation. And we have two major branches, the right coronary artery, which comes off of the right cusp of the aorta, responsible primarily for the inferior wall of the left ventricle, the right ventricle, and in most situations, the posterior component of both right and left ventricle. And the left main coronary artery, which splits into two divisions, and there are many more than those two, but those two are quite important, the left anterior descending and the left circumflex. What we're concerned about today is really not talking about STEMI or MI. We're really talking about what vessels actually supply our electrical component. So very important to appreciate that the left main bifurcates into the LAD and the circumflex. And first, when we look at the left anterior descending coronary artery, the left anterior descending coronary artery supplies the left main bundle branch. Now, what does that mean? It means you have a short path of your left bundle branch block, your left bundle, which is, of course, the superhighway of electrical activation for the left ventricle. And there's just a very short branch that's called the common bundle. And then it splits into two, the left anterior descending, the left anterior fascicle. I'm sorry, I'm getting my head all messed up. The left anterior division of the left bundle and the left posterior division of the left bundle. More on that in just a moment. Now that left main bundle, before it bifurcates to anterior and posterior, if we have an infarct or ischemia to that area, you will have a complete left bundle branch, which means you'll activate the left ventricle from the right heart over cell by cell by cell, taking a long delay with a very clear presentation, because it's a pure left bundle branch block with both bundles deactivated when you have a ischemia or infarct at the common bundle. But it is more common to see a loss of the anterior division of the bundle branch, and that's, again, supplied by the left anterior descending coronary artery. That left anterior descending coronary artery supplies the anterior fascicle of the left bundle, and it also supplies the right bundle. And then the circumflex, which circles around the side, coming off of the left main coronary artery, circumflex circles around the side, and it gives rise to blood flow that primarily supplies the sinus node, partially supplies the AV junction, and can supply the posterior division of the left bundle. So again, the worst situation is you have a left main occlusion of the coronary artery, you infarct the full left bundle before bifurcation, you'll be in a full left bundle branch block. Your anterior and posterior division will not be functional. Now that's two of the fascicles. That's called a bifascicular block of the left bundle. But it is really important to remember that for the majority of persons, the majority of anatomies, the right coronary artery, which comes off the right cusp of the aorta and descends down, supplies the whole right ventricle, the inferior wall of the left ventricle, and for most individuals, supplies the majority of the AV junction and also supplies the posterior division of the left bundle. So this was a very good design. The design is assumed to be perfect because in general, you can have a major MI, a major coronary arterial occlusion, and still hopefully have one superhighway that activates the ventricles. So again, the superhighway to the left has two divisions, the anterior division and the posterior division. The common bundle splits anterior and posterior. So you have two divisions supplying electrical activation to that big old massive left ventricle. And then the right coronary artery supplies, always really, really important for us to remember, the right coronary artery may supply the posterior surface and provide blood flow to that posterior fascicle. So left-sided circulation responsible for absolutely for everyone, left anterior fascicle, right bundle. And the posterior dominant circulation for most people is the RCA, supplies the posterior fascicle. So let's just take a really quick look at these bundles, just remembering that once we've activated the atria, the impulse is gathered in the AV node or the AV junction, sent down into the common bundle, and then into the bifurcation to the right and the left bundle branches. And that left bundle, remember, you've got that nice common bundle and the bundle of His that then splits into the anterior and the posterior division. So we have three major superhighways activating both the right and the left ventricle. And the design is such that if one or more of your special superhighways, those bundle branches, actually infarct or are taking too long to repolarize, you can still activate the ventricle. It's going to be done slowly because now instead of the superhighway, which is the bundles, you are activating cell by cell by cell. So you still activate, but it takes a lot of time. And that's what's really important. So we're going to look at two things really importantly. When we look at bundle branch block, we look at two things. Is the current, the direction of current normal, which means to the left, or abnormal, which means to the right? Is the direction normal or abnormal? And how much time does it take? That's really what we use when we look at a bundle branch block. Normal direction and how much time does it take? Now, there are going to be a couple of other things that are going to help confirm that we have a bundle branch block and that give us a lot of additional information. So we're really lucky to have that kind of information that's really easily available to us with an EKG. So again, I just want to reiterate this. Here's your AV junction, the bundle of His, and that common bundle of His actually then bifurcates, right? It bifurcates to the right and the left bundle bifurcates to the posterior fascicle and the anterior fascicle. Now, a couple things that are really important. The right bundle is very affected when you have a rapid heart rate because it takes longer to repolarize. It's to the right ventricle. It doesn't get the same amount of oxygenated blood flow, and it takes a little more time to repolarize. So very common when you have rapid heart rate to actually be accepting that electrical depolarization into the bundle structure in a right bundle branch block pattern. Now, when I tell you that a bundle is blocked and you hear the word right, it means that a lot of current will be going towards the right because it's going to be cell by cell by cell. So you depolarize the left ventricle really fast and you depolarize the right ventricle really slowly. And that's what tells us about a right bundle branch block. Want to remind you, the most common wide QRS tachycardia that we see, so it's tachycardic with a wide QRS, the most common is actually supraventricular tachycardia with a right bundle branch block pattern, which is why we all really have to understand the bundle branch block patterns and how to make a diagnosis quickly without too much stress and with a fair amount of reassurance. Now, it used to be a lot more important when you had somebody with really a rapid heart rate and you couldn't tell whether it was ventricular or supraventricular with the right bundle branch block pattern. You treated those two dysrhythmias very differently. In today's world, it's not nearly as important because we treat them the same. We give them both potassium channel antagonists. Of course, that's amiodarone. And so that's made things a little bit easier, not requiring the same amount of critical thought to analyze the bundle branch block pattern, but it still is significantly important for us to do. Now, when we look at the left bundle, remember those two major divisions. It's called a little septal tail. That's a little important piece, but more for a big 12 lead EKG class and not for a 1 hour evaluation, but it is an important piece. We're just looking at the anterior division and the posterior division. And what you're not seeing here is that the anterior division is very fragile, and the posterior division is a much stronger network of fibers. So remember, with LAD disease, you can expect a right bundle branch block and a left anterior fascicular block. We covered those last week. And with a left main or a proximal left anterior descending coronary artery lesion, or a circumflex lesion, or in a posterior dominance right coronary circulation, you can expect loss of that posterior fascicle. Now, that posterior fascicle is really, really important because it's a really strong fibrous band of electrical activation tissue. And if you only could choose one to have, that's the one you want. So we're always worried when we see posterior fascicular block. Now, moving from that, just as again, as a quick review, we always have to know what the generalized current direction is. That's called axis. So don't let that get you worried. The words axis and axis deviation, they're just big words with really straightforward meaning. All we're going to do is choose the frontal plane leads. Those are the limb leads. Leads 1, 2, and 3, AVR, AVL, AVF. We're not talking about the chest leads right now. Talking about the limb leads, the frontal plane leads. And we're going to choose 2 leads from the limb leads. One that represents the left side, that will be your lead 1, and one that represents the foot side, and that will be AVF. So when I look at an EKG, the very first thing I do is I look at lead 1 and I look at AVF. If current is coming towards the left, and of course it's to the left and towards the apex, I should see an upright picture in lead 1 and an upright picture in AVF. Upright in lead 1, upright in AVF. Always, always, always. Both should be upright. That tells you that you have normal directional current. Now that's in the frontal plane leads. So it's going to be a little different in the chest leads. But in the frontal plane leads, upright in 1, upright in F is normal direction to the left and towards the foot, towards the left foot, upright in 1 and upright in F. Using lead 1 to represent the left, using AVF to represent the foot, and more significantly, the right. So AVF representing the foot and the right, lead 1 representing the left. We're only going to use, in this course, we're only going to use these 2, and you want to remember both of them should be upright. Now, changes to direction occur when you have bundle branch block or you have fascicular block, either anterior or posterior. And changes occur when you have infarction. So it's really important to be able to do a quick look for the axis and say, I expect it to be upright in 1, that's my left hand pointing up, and upright in my foot, both upright. That's telling me normal access. If I'm looking at your EKG and it's upright in 1, we're upright towards the left, but downwards in AVF, that's a left axis. It's so straightforward, okay? In the simple way. This is a simple way. It might not be the way that you would want to write on an EKG or write in your chart, but simply for us to evaluate. If you are downwards in lead 1, and upright in AVF, so I'm using my right hand, I'm opposite you, this is my right hand, downwards in 1, upright in F, that's a right axis. I'm pointing up with my right, that's a right axis. If it's down in AVF, the right-sided measure, and down in 1, that's a completely abnormal axis. You don't know what direction it's going. So it's really straightforward. I'm doing this pretty quickly. I did it last week, and really understanding axis does take some practice, but we can do it pretty easily. So we're going to take a look at this EKG, and I'm going to mark out the chest leads because we're not talking about them right now. And I'm going to choose lead 1 and AVF. And I can see in lead 1, it's upright. And in AVF, it's upright. So this is a normal axis, upright in one, upright in F. It has to be primarily upright in one, primarily upright in F. And everybody can see that both of those are upright. Different from when you look over here, just as to make a comparison at AVR when it's downwards, okay? But I'm not using AVR, I'm using lead one and AVF. Up, up, normal axis. Perfect, perfect. So now let's take a look, okay? So we're looking at lead one here. I thought I had a highlight on there, but I don't. I guess I don't. Okay. So upright in one and upright in F. Up, up, normal axis. Pretty straightforward. Same EKG. Now comes the drawing. Upright in one, upright in F, normal axis. Fantastic. Really straightforward and very easy. The next thing we have to do to understand bundle branch block and fascicular block, we have to be able to do both in axis. And we also have to look at something called R-wave progression. R-wave progression, now we're leaving the limb leads behind, leads 1, 2, and 3, AVR, AVL, AVF. They look at the front of the heart. Now we're leaving those behind. We use those for axis. And now we're going to look at the chest leads. The chest leads actually look on a horizontal plane through the heart rather than across the front. So in every single lead, we expect to see some balance of upright and downwards, upright and downwards. And when we talk about V1 lead, that's our right-sided chest lead on the right side, the patient's right side, fourth intercostal space, right side of the sternum, all the way over to the extreme left lead, which is V6, which is at the fifth intercostal space, the mid-axillary line. So I've encompassed my heart with the V1 lead for the right and V6 lead for the left. And we remember that when we're doing an EKG, we're looking at one impulse from two angles. So I always say it's like $1 million. That $1 million is always going towards V6. So the picture in V1 is going to be downwards. I'm so sad. The $1 million, the million vectors, the million currents, they're going away from V1. That should be mostly downwards. And because they're going towards V6, that should be mostly upright. That's pretty straightforward, okay? Down in V1, upright in V5 and 6, okay? But at some point when we're looking at these horizontal leads, we expect to see more upright than downwards, okay? And we're going to look at this picture to help us understand that. So you see here, this is a normal V1. Here are my leads placed around the heart, and the current is primarily going towards the left, which means away from the right. So I have a downwards on the right side lead. I have a little upright, but mostly downwards. A little bit bigger upright, but mostly downwards in V2. When I get to V3, I have a bigger upright, still a little more down than up. But when I get to V4, it's more upright than it is downward. Now that's really important. First and foremost, this is called R-wave progression. It's one of the most important aspects of evaluating a 12-lead EKG. We're only doing that in the horizontal plane leads, V1 through V6. Remember, we use the limb leads for axis. We're going to use these leads for R-wave progression. And we're going to use lead groups like inferior, anterior, lateral for STEMI evaluation. But for bundles and for looking at current as it goes through the heart, we'll use limb leads for axis and the chest leads for R-wave progression. Now, two really important things. We expect it to be tiny or absent in V1 and to get bigger, 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 big, so that you actually have more upright than downwards, either in V4 or V3. So these two leads are where you normally have more upright than downwards. That's known as zone of transition. And oh my God, is that the most important thing? Way more important than remembering right rabbit ears and all that stuff that 90% of patients don't follow. So if that's what you're relying on, you're going to have trouble diagnosing them. You want to be able to talk about R-wave progression, small, bigger, bigger, big, small, bigger, 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 big, R-wave progression, going up a staircase of voltage. And the zone of transition. Zone of transition means that upright is bigger than downwards, that should happen at V3 or V4. If it happens early, probably the probability is you have a right bundle branch block. That's one of the most important things. Early zone of transition, meaning you transition in V1, more upright than downwards in V1. That's typical for right bundle branch block. And with left bundle branch block, you tend to have a normal to late zone of transition. If you have a late zone of transition, you're going to think bundle branch block. Now, there are other things that cause an alteration in R-wave progression. Of course, a big anteroseptal or anterior MI where you've wiped out tissue, it's no longer conducting. All those kinds of things are going to cause problems. But for our purposes today, what we want to be able to do is look at axis and look at R-wave progression, zone of transition, is the direction to the left, and how much time does it take? That's going to be pretty straightforward. Okay, so now I've knocked out my limb leads, and now we're going to look at our chest leads, our horizontal plane leads, starting with V1, tiny little R wave, V2, a bigger R wave, and in V3, the upright, the R wave is much bigger than the S wave, the downward. So this V3 is my zone of transition. And I continue to march all the way through, small, bigger, bigger, big, 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 not necessarily bigger than in V5 and 6, but it's still upright, still big. So this is called a normal R-wave progression, a normal zone of transition, and a normal axis. Okay, I walked it all the way through. Okay, so we go back to our patient from before, right? Normal axis and little r, a little bit bigger, and zone of transition, V4. So good R-wave progression with zone of transition in V4. That's your zone of transition where the upright is bigger than the downwards. So you might have thought it was here, but downwards was still bigger than the upright. Zone of transition is here, V4. That's a normal zone of transition. That's really important. Now, when we look at bundle branch block, we're only going to choose 2 leads. Now, remember, for axis, we choose 2 limb leads. For bundle branch block, we're going to choose 2 chest leads. We're going to choose the V1 lead, which represents current towards the right, and the V6 lead, which represents current towards the left. Current should always go to the left, to the left, to the left, to the left. All your voltage ought to go to the left. So that means in V1, you always expect that to be primarily downwards. And in V6, you always expect it to be primarily upwards. That's really important. So when I'm looking for a bundle branch block, or I'm concerned that the patient has a bundle branch block, I always check V1 and V6. Remember, 2 photographic views of the same electrical depolarization. So direction normal means always to the left, which means that that current's going away from the right. So you'll be upright in V6 and downward in V1. Now, if the direction is to the right, which is the wrong direction, it means it's going primarily towards the right. So V1 has a primarily upright, and that means we've taken it away from the left. Now, you still have to depolarize the left heart. You still have a left bundle, so you've activated the left heart. But now cell by cell by cell by cell sent over to the right. So what we then see in that individual is that they have a large upright in V1 or V2 with a large downwards at the end of electrical activation in V6. And by the way, it just takes too much darn time. So just as a quick overview here, we're looking at V1 and V6 on this first screen. See a small upright in V1 and a big downward, completely opposite in V6, a small downward with a big upright. So it's not just a mirror, it's an upside down mirror image. In right bundle branch block, we have a small upright, then a downwards, then another upright, but the major current is to the right. And we see that inscribed on our left sided lead. We, of course, activate the left heart, but then current goes away from the left and back towards the right, inscribing that downward. And today our focus is left bundle branch block, and primarily complete left bundle branch block. So what you see in your V1 lead is current goes away from the right heart And it's taken a lot of time because my whole left bundle, both the anterior and posterior fascicle, are blocked, which means so much current has to be sent over to that big old muscular left ventricle. And you see in the V6 lead, the direction of the current is normal. It's going to the left, but it's taken a lot of time. Now, whenever you have abnormal depolarization, you will also have abnormal repolarization. Hence, with bundle branch blocks, in the leads you're using to look at the area where there's abnormal depolarization, you will also see abnormal repolarization. So we're going to take a couple looks at it. Okay, so this is a 58-year-old man who's having some chest pain. We're going to first look at his limb leads. He's upright in one, and he's primarily upright in AVF, although it's almost equiphasic, meaning what goes up and what goes down are almost equal. So we're going to say this is a relatively normal axis, up in one, up in F. And then we go over to the chest leads and we say, uh-oh, big R wave in V1, upright is bigger than downwards. That's the zone of transition. Woo, whenever you have an early zone of transition, meaning more upright than downwards, it's in V1 or V2, first thing you got to do is say, how wide is this? And it is 1, 2, 3 boxes, meeting criteria of 0.12. Anything greater than 0.11 indicates that you have a depolarization deficit. Now, does this patient have other problems? Yes, he's got chest pain, he's got STEMI, he's also got a right bundle branch block. He's got a right bundle branch block. And sometimes in the face of STEMI, that can be very difficult for you to evaluate that he's actually having the STEMI because he has a bundle branch block. So that's why we go over this. Now, I talked about right bundle branch block last week, so I'm moving now on to look at the other condition. Oh, the blocks, the left bundle branch block. The left bundle branch block, impulse is transmitted very quickly to the right and then returns to the left. And all that current's going to the left, cell by cell by cell by cell. Impulse to the apex and to the base of the left ventricle takes so much longer. So the time is wide. Time will be wider than 0.12. Normally, your ventricles are depolarized in 0.08 to 0.10. So even at 0.11, we're concerned. But in left bundle branch block, always wider than 0.12. In a full left bundle branch block, always wider than 0.12. Direction normal, time is long. Direction normal to the left, but time is long. And your zone of transition may be normal. It won't be early. It might occur in V4, but frequently it will occur in V5 or V6. So that's really important. Now, why do you even care? People are like, why do I care about access and bundle? Oh my God, are you kidding? It's so incredibly important. Left bundle branch block, unlike right bundle, remember you can get a right bundle branch block that's rate related. Left bundle branch block is never, 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 never normal, never normal. It is something that occurs when you have cardiomyopathy, when you have myocardial disease, when you have an acute coronary syndrome, when you have heart failure, when you have hypertrophied left ventricle, you can also see a left bundle branch block. So that sounds like a lot of our patients, and indeed it is. Okay, so this is really important. It also can be one of the earliest signs of an acute anterior myocardial infarction. So just remember that LAD, the left anterior descending coronary artery, the most common vessel that is occluded, actually supplies that common bundle of His. That common bundle of His before the bifurcation to anterior and posterior. And you can lose your left bundle. And what's really important to remember is if I have a high grade left anterior descending coronary artery occlusion, I may first see my patient with the first degree AV block and a left bundle branch block. But I want you to remember, if it's LAD, the The LAD also supplies the right bundle. So your patient is profoundly at risk for complete heart block when this occurs, which is why you've got to be able to quickly look at it and make some assumptions. Maybe you need confirmation from a cardiologist, no harm, no foul, but at least notice it, because that patient may have an asystolic cardiac arrest. He goes into complete heart block, and you could have anticipated that because he was having anterior myocardial ischemia. He had a left bundle branch block as a first-degree AV block, but now he has a supraventricular dysrhythmia. Now he's got a right bundle branch block in addition because his rate is so rapid, and now he's in complete heart block. And patients who go into complete heart block for this condition, by the way, epi and atropine ain't going to work for them. You can do CPR, and you've got to get a pacemaker on board, and that needs to be quickly. Now, pacemakers have kind of fallen out of favor in our ACLS guidelines. That's because nobody wants you to pace a patient that doesn't need it. This patient's going to need it, though. Okay, so I want to remind you, with a left bundle branch block, the septum, the dividing wall between the right and left ventricle, actually will depolarize abnormally, right? Normally, the septum depolarizes from the left towards the right, so meaning away from your left-sided lead and towards your right-sided lead. But that septal tail, remember I said that little septal tail, that was so important? If you've got a complete left bundle, that's also not going to be active. So actually, you're going to start the activation of the heart on the right side via the right bundle. And then all that current's going to go to the left. So in V6, you're going to see an entirely upright depolarization all above the baseline and taking a lot of time. So you're going to have a big wide R on the left side and a deep downwards on the right side. That's typically called a Q wave or a QS wave. It's just down, down, down when you're visualizing from the right-sided lead, and up, up, up when you're visualizing from the left-sided lead, taking time, 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 because it's an abnormal depolarization. Okay, so we got some strict criteria for left bundle branch block. So this is the V1 and the V6, same depolarization viewed from two places. Strict criteria, got to be wider than 0.12, no arguments there. The wave is very broad, both in 1 and V6. See how broad that wave is. It's really wide, really wide. And in V1, you had, this is not a Q wave. This is an S wave. So really, this is not a Q because you have that tiny little R there. So this is a very deep S wave. It could be a QS wave, but this is just a deep S wave. And you don't have any Q waves in V6, which you normally do. You have small Qs in lead 1, AVL, V5, and 6, as the septum depolarizes from the left towards the right, but we've lost that. The stricter criteria, and these are really the stricter criteria, you in two contiguous leads, meaning two leads in a lead group. So the anteroseptal lead group, the anterolateral group, two of those leads like V5 and 6 or V1 and 2, that you will basically have what we call notching or slurring in that QRS. Okay, that's required. Okay. QS, or very tiny R, see that little R, and big S, QS or RS in V1, V2, and the width typically in women should be greater than 130 milliseconds. So that would be 3.5 boxes. And for men, 140. So that would be 3 3/4 boxes. So, hey, anything greater than 0.12, we're going to consider that. And remember, the current is always going to the left, and it's taking a lot of time. So now let's again look at this criteria, because this is really important. In the V1 lead, you can just have a QS, or you may have a little tiny R wave and then a really deep S. And that will be upside down and mirrored in the V6 lead. So typically no Q wave and this big wide R wave. We've lost our Q because we're not activating the septum in the normal way, and it's taking lots and lots of time. That's what you want to remember. It's taking lots and lots of time. But there is something else that's really important, and that is the idea of discordance. Discordance means that in general, you expect the T wave to go in the same direction as the ventricular depolarization. That means if it's primarily upright, the T wave should be upright. If it's primarily downwards, the T wave should be downwards. Now you call that inverted, you might call it negative. I don't like to do that because that gets confused with the lead placement. So T waves should go in the same direction as your ventricular depolarization. Discordant T waves are very common to see in patients with bundle branch block. And that's going to be really important to you because that helps you to differentiate when your patient's having an MI in the face of a bundle branch block. So with the right bundle branch block and V1 through V3, your T waves, your R waves are upright, but your T waves are downwards with right bundle branch block. With left bundle branch block, your R waves are upright and your T waves are downwards. So remember, you're going to expect the T waves in the opposite direction in the leads that are designated for that side of the heart. Okay, so I'm again going to remind you, V1 represents the right heart, V6 represents the left heart. Now it's really V1 and V2 and also V5 and V6, but we're just going to choose those two leads to say, I'm going to compare V1 and V6, assuring that leads have been placed correctly, because that's a big boo-boo that can happen. And I'm expecting that if my ventricular depolarization is upright, meaning it's primarily an R wave, that my T waves will be upright as well. Okay. So again, really, really, really important when we're talking about T wave changes and bundle branch block. Okay, you can see here in 1 and 6, lead 1 and V6. Here's your upright and your downward. This is right bundle branch block. And in V1 and V2, right bundle branch block. Sorry, this is a left bundle branch block. This is a right bundle branch. I'm sorry. This is a right bundle branch block. And remember, we still activate the left heart in an upright direction. So sorry about that. Okay, so you can see your T wave in your V6 lead with the right bundle branch block is upright, but your T wave in your right side leads V1 and V2 is downwards. And now we're going to go over here for a left bundle branch block, also the same if you have a pacemaker, because that's always when your pacemaker is actually your transvenous pacer, the wire is typically embedded into the right ventricle. So you're going to actually activate the left ventricle in a left bundle branch block pattern. So remember, you are going to be primarily upright here in your V6. And you can see that I downloaded this visual. Oops, sorry about that. Oh, and now it says I redirected you. And your T wave is discordant. Upright depolarization, discordant repolarization, meaning the opposite direction. And the same thing here, this is in V1 or V2, that I have a downward activation with an upright T. So again, what you're seeing here in right bundle branch block, because the right ventricle is much less powerful and much less consumptive. In the right-sided lead, I have a discordant T wave. Okay. In my left-sided lead, I don't have a discordant T wave. It's going to go in the same direction. And when I look over here with left bundle branch block, it's upright with a discordant T in my V6 lead. I would have preferred this to be reversed, that we look at V1 first and then V6. That's what confused me in the beginning, because normally that's how we look at it, but it's not my visual. I downloaded it from someone else. Okay. Now, I have a really great colleague named Muhammad Burim, and he always asks me about Sgarbossa's criteria. Sgarbossa's criteria is the way that you identify infarction in the face of a left bundle branch block. Okay, so first of all, the criteria will correlate to ST segment changes and how big those changes are. So that's going to be really important. And then it's also going to be T wave concordance. Okay, so we've already talked about that, and it's pretty straightforward. All right, so let's just start with this one. You can see first for axis, you can see you are upright. Just trying to, whoops, sorry, trying to get my cursor working. But anyway, upright in lead 1 and upright in AVF. So normal axis. Okay. And then when I look at my V leads, I see it's downwards in 1, downwards in 2, primarily downwards in 3, primarily downwards in 4, and it finally becomes upright in V5, which means that is a late zone of transition. And when I look at V6, I see that my ventricular depolarization here, in this case, it's an R, is wide, and I have a discordant T wave. So I have a normal axis, I have poor R wave progression, I have late zone of transition. The direction is correct. Direction is correct, but it takes a lot of time, and my T wave is discordant. This is the left bundle branch block. So remember, we've looked at that before. It's really important for us to remember that we are going to see some abnormalities in ST segments and T waves when we have bundle branch block. And they're going to be much more significant when we talk about somebody with a left bundle branch block. So now let's take a look at this one. Upright in lead 1, upright in AVF. So normal to not left axis. This is really just a normal axis. A normal axis, yes, sir. And then we look at R wave progression, and we see the R wave in V1, V2, V3. R wave in V1, V2, and V3 are really, really small. And then I have zone of transition in V5. So when I get to V5, I don't know why that thing is coming up, but that's okay. When I get to V5, I see that it's upright and wide. So direction is normal, but it took lots of time. And I actually see this pulling down of my ST segment. So this is actually more than just a left bundle. We're going to come back to that in just a minute. And we look at this again, upright in 1, primarily upright in F. It's kind of small. This is a normal to left axis deviation. Yep, yep, yep. And when I look at my chest leads, my horizontal plane leads, starting with V1, I see a deep S, a deep S, a deep S, these tiny, tiny little beeps right there. Those are R waves. So this is an S wave, an S wave, an S wave, an S wave. And I finally transition in V5. That is a late zone of transition, and my time is wide, and I have some other abnormalities. So I don't absolutely have a T wave inversion here, but I do have some other abnormalities as it relates to my ST segment. So normal to left axis, zone of transition, V5, that's late, poor R wave progression. Direction is going to the left, which is correct. It's the right direction because it's going towards the left, the correct direction, but it took a lot of time. This is a left bundle branch block. Okay, so remember, you're looking at your chest leads to determine the axis. Must be upright in 1, must be upright in F. That's a quick look axis, not always going to be 100% correct because it's a little more intensive than that, but it's straightforward for us. Up in lead 1, the left side, up in AVF, upright, upright, normal axis. And then I go over to my chest leads, and when I'm looking at my chest leads, I see that I have, a late zone of transition and T wave inversion. And that means I meet the criteria for left bundle. Current towards the left takes a lot of time. I have a late zone of transition, and my T waves are in opposite directions. Now, most of you will notice, if you're paying a lot of attention, that V1, V2, and V3 have ST segment elevation. The number one cause for false STEMI activation is left bundle branch block. Because the left ventricle is so large and the current has changed so much, you will install an ST segment elevation, V1, V2, and V3. Now, it doesn't mean that the patient's not having an infarct. That doesn't mean that at all. But we actually have to look at how much ST segment elevation there is, and is it in the face of a left bundle branch block? If I have a left bundle branch block and I see this ST segment elevation, I'm not really sure. I might be having an anteroseptal MI. My patient's complaining of chest pain. By the way, I'm not going to activate STEMI, but I am going to call the cardiologist and ask them to look at the EKG. I'm going to leave it in the hands of the people who study EKGs, and that's what they do. I don't ask a cardiologist to do continuous renal replacement therapy. I don't ask a surgeon to do a cardiac cath. Why do I think it's okay for everybody and their brother to take a diagnostically uncertain EKG and activate the cath lab? Don't want to do that. If I am not certain, I'm going to call the cardiologist. Takes a minute for them to look at the EKG, and then they determine whether or not we need to activate. All right, now we're going to take a look at this one. I can't remember if I instilled. Oh, yes, I did. Okay, so first and foremost, upright in 1, upright in F. Remember down here, that's a rhythm strip. So 1 and F, both upright, up, up, normal axis. Now I'm going to look at my R wave. I don't really have a tiny, teeny R here, tiny, teeny R here, a tiny, teeny R here. I transition in V4. It's all upright in V4, but oh my God, look how broad that is. It is so wide. So I'm meeting the criteria for a left bundle branch block. Direction to the left, upright in V6 took a lot of time. And here I have a normal transition. So, okay, the major criteria are that I am really taking a lot of time for activation and the current is to the left. Okay. Again, another patient here, upright in 1, upright in F. So I have a normal axis because I'm activating really from the right heart. And so I'm activating towards the apex and the base. And that's going to give me basically a normal axis. Sometimes it might give me a left axis, and that's okay too. But it's upright in 1 and upright in F. So I've got a normal axis. Now I'm going to look at R wave progression. And yet again, my R wave progression is really poor because it really should get much bigger by V3 and transition by V3 or V4, but I transition late here. Very wide R wave. And I have an upright T here because I probably am also having some myocardial ischemia, but I can very clearly say my patient has a left bundle branch block. Normal axis, direction going to the left, takes a lot of time, and it has late transition. Now you're like, oh God, why do I need to know this? Oh my God. Oh my God. Because when you have left bundle branch block, you have discoordinated, uncoordinated, dysynchronous activation, mechanical response of the ventricle. So the right ventricle contracts, and then the left ventricle has a delayed contraction. So there's a problem with the septal wall and the way that that moves. There's a problem with the way the ventricle, particularly the left ventricle, actually is going to fill with volume. It's going to be very inefficient. It's going to be inefficient filling and inefficient ejection. And because it's a bundle branch and it's going slow, 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 so I'm going to try to use my hands the best way I can. Your normal left ventricular activation through the anterior and posterior wall is super fast, 0.04 seconds, and then a contraction. Super fast, contract, super fast, contract. Now I'm going to have to put my hands like so, just so I can show you. Now, because it's cell by cell by cell, it's super slow contractile response. And because it's a super slow contractile response, you don't generate enough pressure to actually overcome effectively the resistance of the aortic valve. You don't actually create what we call the rate of rise in the pressure that actually rapidly opens the aortic valve and boluses that blood out. So the amount of blood ejected by the ventricle is significantly and profoundly decreased. That can actually put your patient into a form of cardiogenic shock or heart failure because it's a left bundle branch block. That's why you need to know it, because you're like thinking, well, this guy's hypotensive, he might be septic. I'm going to give him a couple liters of volume. Well, he's got a left bundle branch block. That's going to kill him. It's going to kill him. You got to know what the patient is doing electrically so we can do the right thing for them. Now, having talked about left bundle branch block, I just want to remind you about your 2 divisions of your bundle. So this red one here is your right bundle. And over here, you have the anterior and what's representing the posterior. So this is the anterior and the posterior. So if I have an anterior bundle branch block, I'm going to activate, and not the posterior, I'm going to activate from the posterior fascicle, which means away from the left as it goes to the apex and then back up to the left. So in my lead 1 and AVL, both sharing the left side electrode, I'm going to have a small Q and a big R. And in my inferior leads, I'm going to have a small R and a deep Q. Now, unless you're really interested in EKG, you're never going to look at this. You're not going to be really worried about it, except for one thing. You pray that your patients do not have a complete left bundle. But patients have incomplete left bundle. And with incomplete left bundle, what they're primarily going to show you is a small bit of widening, usually about between 0.10 to 0.12, not wider than 0.12, but wider than 0.10, and an axis deviation. So with anterior fascicular block, you will have a left axis deviation because it's primarily upright in 1 and primarily downwards in F. You will have a left axis deviation. With an anterior fascicular block, you have a left axis deviation. With a posterior fascicular block, so what's going to happen is you activate up towards the left and then all current goes down to the foot. You will have a primarily downwards in lead 1 and AVL sharing the same positive electrode, and a primarily upwards in AVF. Okay, so it's up in AVF and down in 1. That is a right axis. So with posterior fascicular block, you'll have a right axis. With anterior fascicular block, you'll have a left axis. Now, this is complex. It is not simple. I'm not trying to say it's simple, and I'm not trying to make everybody into a high-level cardiologist. I just want you to remember that if your LAF is blocked, then you just have your left posterior. And LAF gives you a small Q in 1 and a big R in lead 1, and a small R in F with a deep S. And that's going to be a left axis deviation. With the posterior, the left posterior is blocked, so you just have 1, and that's going to give you a right axis deviation. Small R in 1 with a big S, and a small Q in F with a deep R. Now, this is a lot of information, but it's really important because we can see that we're looking at a patient that actually has both fascicular block as well as bundle branch block. This patient, so let's take a look at our patient. So our patient has a right axis deviation. He has a right bundle branch block. But when we look a little bit further, we see a small R in 1 with the deep S and a small Q in AVF with a big upright. So he has 2 fascicles blocked. And why you care about that is because now your patient is activating his heart with the absence of 2 of his fascicles. He only has 1 fascicle left. And your concern is that he could have complete heart block. And you're prepared for that. That's the reason you care. You need to be prepared. Now, with LBB and MI, what we can often see with these patients is that left bundle branch block mimics and masks acute MI. So it used to be part of the ACS criteria, acute coronary syndromes criteria. New LBB was diagnostic for ACS until proven otherwise. But now we say really like less than 2% of all patients have a new onset left bundle branch block with an acute coronary syndrome. So really unusual. And that's where the Sgarbossa criteria come in. So I'm going to try to make this as simple as possible. Sgarbossa criteria talks about discordance. In normal left bundle branch block, ST segments ought to be isoelectric. And if they're not at the baseline, they should be opposite. So if I have an upright R, my ST should never be upright in that lead. The ST segment should be normal or downwards, and the T wave should be downwards. So discordance, meaning everything is not going in the same direction. With a STEMI, what you typically will see is an R wave with ST segment elevation and a highly peaked T. And as time goes by, that T wave may flatten and invert, but that doesn't happen. That doesn't happen while the patient's having their ST segment elevation. So you're always looking at concordance when you're seeing a STEMI. With a bundle branch block, you always expect discordance. So in V6, I expect discordance. But if it's concord, meaning I have a big wide R wave with ST segment elevation, that's a STEMI. So that's really important. Discordance proves bundle branch block. Bundle branch block with STEMI will not be discordant. That's about as simple as I can make it. The law of discordance. Okay. I have a bundle branch block here, and I see my ST segments are down. My T waves are upright here, but my ST segments are in the opposite direction. They should have been flat, but they're down, right? Down or flat. They should never be elevated. And the opposite lead group, which is my right-sided leads, V1, V2, and maybe extension of V3, they are primarily downwards, but they've got ST segments and T waves that are upright. That's discordant. This is pure bundle branch block. That's Sgarbossa's criteria. Sgarbossa's criteria is expect discordance. If you have concordance, it isn't just bundle branch block, it's something else. And there are very particular points that are applied here. So the most important thing, look at what it says. You get 5 points. So look at this in Sgarbossa's criteria with the left bundle branch block, you have ST segment elevation. You got ST segment elevation with bundle branch block, ST segment elevation, you get a lot of points. You're having a STEMI. It's really straightforward. I don't expect your STs to be in the same direction. So if it's all downwards, I don't expect the STs to be down. If you're upright, I expect STs to be down and T waves to be down, one or the other or both. But if they're all going in the same direction, that indicates STEMI. That's Sgarbossa's basic criteria. So overall, concordant ST segment elevation greater than 1 millimeter in at least 2 leads of a lead group is the most specific for MI. When I look at V1, 2, and 3 in left bundle branch block, I always have discordant ST segments. But if I have ST segment depression in V1, V2, and V3, that's specific for MI. This is very straightforward, guys. Discordance typically means this is a abnormal depolarization, not a STEMI. So no one's asking you to memorize Sgarbossa, but I want you to see this. Look how you're downwards here, and you have ST segment depression. This is called concordance. This is a STEMI. This is actually an inferior posterior STEMI. Okay. Yes, you have bundle branch block. Yes, you have bundle branch block, but you expect on the right side of the heart to see discordant ST segments, meaning ST segments should be up when the current picture is downwards, and they're not. They're discordant. Discordance is a problem. So these are Sgarbossa positive EKGs. That means that we've got ST segment elevation here that is higher than the criteria, greater than 2.5 millimeters. And you have ST segment elevation in other leads. And here you have ST segment depression in leads where the ventricular depolarization is downwards. So we really just talk about this in terms of ratios, that it's really basically 2 to 1 or greater than 2.5 to 1 from the R wave to the ST segment. That actually indicates to us that we have a patient who might be having an infarct. So again, 3 basic criteria: that your ST segment elevation is in the presence of an upright QRS complex, that's concordance, and it's greater than 1 millimeter. ST segment depression, concordant with a downward ventricular depolarization, V1, 2, or 3, or ST segment elevation is greater than 5 millimeters elevated. It's straightforward. Concordance and degree. Okay, concordance and degree. Fantastic. Fantastic. So when we look at this, we say, oh, axis is normal. Whoop, terrible R wave progression. Zone of transition, V4, really wide. I have ST segment depression in my extreme left-sided leads, V5 and V6, and that depression is opposite the QRS, which is upright. And then I go over here and say on the opposite wall of the heart, I have all downward, and I have ST segment elevation. And what I now have to say is it greater than 5 millimeters? And no, it's not. So by the way, this is not a STEMI. This is left bundle branch block with discordance of your ST segments in your right-sided leads, reflecting your left bundle branch block because it's so significant with a normal axis. Fantastic. Okay, so we meet our basic criteria there. And here's a left bundle branch block with no injury at all, just like some of the ones we've already looked at. You can see that here, you're upright in one, you're upright in F, but it's sort of on the edge. This is normal to mildly left. You can just say normal axis. Poor R-way progression, late zone of transition, really wide. ST segments are discordant. And in my right-sided leads, V1, V2, V3, I also have discordant ST segments, but they are not taller than 5 millimeters. This is not a STEMI. This is left bundle branch block with no injury at all. Here, though, what you're seeing is something very different, okay? So again, I'm looking at my axis. My axis is normal. My R-wave progression is okay. My zone of transition is V4, but it's wide with a little bit of discordance. But now when I look at leads in my lead group, I see that I have ST segment elevation 2, 3, and AVF. And I see that despite having a left bundle, and I would have expected to see ST elevation, V1, V2, and V3, I have ST segment depression. I'm having an acute myocardial infarction, which might have been masked by the fact that my patient had a left bundle branch block. Okay, all right, very good. So we talked about a lot of things. What I want you to remember, every time you look at an EKG, separate first. If you have time, if the patient's not having a profuse STEMI, which is pretty obvious, not always, but generally, if you have time, look at your limb leads. Lead 1 representing the left side, AVF representing the right side. Both of them should be upright. That's normal. Look at your chest leads, V1 through V6. Look for the progression of the R wave. Gets bigger, bigger, big, big, bigger, 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 big, big. And zone of transition should occur where it's more upright than downwards in V3 or V4. Early zone of transition, always look for right bundle branch block wider than 0.12 with discordance of the ST or the T wave in V1, 2, and 3. That's not enough to be instilled on the opposite side of the heart. But when you have a left bundle branch block, because the left ventricle is so big, it changes everything electrically. With the left bundle branch block, what you're going to look for is a normal to late zone of transition with discordance of the ST segments on the left-sided leads, V5 and 6, and also discordance in the right-sided leads, often V1, 2, and 3. If you have discordant ST segment elevation, you've got an obligation to count the elevation from the baseline. If it's greater than 5 millimeters, that indicates that you've had a STEMI. So hopefully those criteria will help you as you evaluate EKGs and you bring those to your purpose of doing the right care for patients right now, making good decisions, activating STEMI, calling a cardiologist, being concerned, and remember that the person who can best evaluate an EKG is going to be the cardiologist. So when there is diagnostic uncertainty, pick up the phone, call the cardiologist. They have access at home. They can look at the EKG and they can help make a good decision. If you really have no other option, always activate a STEMI. It's better to activate a STEMI in a false activation than to miss a STEMI when you don't activate. But we certainly would like to reduce false activation, and that's the power of knowledge, power in the hands of nurses like you who are at the bedside every day, really providing excellent care for patients, doing the right thing and always striving to know more and understand more. I thank you very much. I'm going to stop recording at this point, but I'm certainly available for questions and answers. Thank you for joining me today on Wonderful Wednesday.